review part one from last week, which is largely we talked about diagnosis, and categories of pancreatic cystic disease. We talked briefly about the ICG, or the International Consensus Guidelines, and I think I'll just review that at high level first, and then go through the rest of the case examples. We had been through one already, just to illustrate the kind of the complexity of the decision making as it relates to the guidelines and how to implement these. And then I think we'll spend most of the talk talking about how to compare, or the comparison of the different guidelines currently available. And then I think a really important point is, how do we think about and use guidelines? Like, are they practical for us, and what do they do to help us? So that's the part we'll end with, but I think is potentially the most important part as you think about going into practice. So just to review from last week, we talked about the fact that there are both neoplastic and non-neoplastic pancreatic cysts. Obviously, the focus today is on the neoplastic cyst, but it's important to, in the diagnosis phase, to think about the fact that there are injury or inflammatory related cysts, congenital cysts, other non-neoplastic cysts that we reviewed last week. The one that's most controversial is perhaps the mucinous but non-neoplastic cyst. And even though I have it here on the screen, I think we should all recognize that this is, I think its import and frequency are really unclear. And then finally, the presence of neoplastic cysts that can be broken down into these categories, I think best illustrated when you think about the pancreatic system and parenchyma as a unit. Obviously, the neoplastic cysts are these mucinous cysts, and then this, obviously the serous cystic tumors also come from the ductal system. We're really not going to be talking today about the solid pseudopapillary tumors, cystic pancreatic endocrine tumors, lymphangiomas, or acinar cell cystadenomas. So we'll focus on these as we did before. Just to review the types of cysts that are probably most common that you will hear about is primarily the serous cystadenoma or serous cystic neoplasm. These are glycogen-rich, cuboidal, epithelial-lined cystic space with really acellular stroma and a lot of collagenous connective tissue. They are in imaging and pathologically really two separate varieties. The kind of pathognomonic one being this one, the microcystic variety. You can see, obviously, this is the sponge-like or honeycomb-like appearance, and then the more problematic for us, but more rare variant, the oligocystic variety or macrocystic. This is because this looks much more like other cysts, either MCN or side branch IPMN. But it's important to remember that this appearance can be a serous cystic neoplasm as well. These are the typical radiographic appearance. I put this because this is a common ABSITE, or at least was a common ABSITE question about the sunburst pattern of calcifications, well illustrated here, and really the honeycomb-like pattern of these cysts in general. Many serous cystic neoplasms that we see now are much smaller than the ones in these pictures. So overwhelmingly benign lesions only need to be resected for symptoms. They do grow, but the rate of growth appears to be quite slow and is not problematic. And very, very rarely they have been reported to transform or to just arise as serous cyst adenocarcinomas. This is extremely uncommon, reported in the literature only in 26 patients over many decades. I think that from a clinical perspective, this should be only brought into question when something looks atypical for a serous cystadenoma, and not something we should remove because it has this very rare chance of transforming. So in general, this, I would say, you should put really in the very back of your mind and the concerns. Really, we only are thinking about taking serous cystic neoplasms out because they're bothering the patient, not at least cognitively, but in some sort of medical way, or because the diagnosis is unclear. And that's, I think, what we'll get to here in a little bit. Okay, mucinous cystic neoplasms, or MCN. I'll just say what I said last week, which is it's really important to not use this term as the overarching term for the whole group of mucinous cyst in the pancreas, because this is a very specific term that's meant for this entity, which is a cyst wall that is lined by mucin-producing columnar epithelium with ovarian stroma. And the ovarian stroma is the pathognomonic feature, and is a really important thing to discuss with pathology when you're thinking about the diagnosis of MCN. When strictly defined, or I would say properly defined at this point, now that this is the pathologic definition of MCN, this is overwhelmingly a disease in women. It's not completely, but very strongly in the body and tail of the pancreas in the vast majority of cases, and usually solitary and slightly bigger in size than what we think of most side branch IPMNs. So MCN, specific entity, important to remember. I think this is a good mental picture of it. It is generally a thick-walled but unilocular cyst. They have focal calcifications that are often distributed about the wall, around the rim, as opposed to the sunburst-like calcification of the cyst I just showed you as serous cystadenoma. And importantly, they do not communicate with the pancreatic ductal system directly in a macroscopic way. Here you can see the pancreas duct just draping on top of one of these cysts. But remember that imaging is not perfect, and that communication suggested by ERCP or MRCP or EUS is not definitive. And so I think that doesn't really rule out the presence of an MCN. An MCN in patients selected for surgery. Okay, so this is being challenged currently because of really the uncertainty about making the preoperative diagnosis of an MCN. But in patients who have an MCN removed, it's important to realize that a much higher fraction of these patients have either a carcinoma in situ or an invasive carcinoma than patients who have a side branch IPMN. And in general, the patients who have this disease removed at an earlier stage, when there is not yet invasive carcinoma, have a much better outcome than those with malignant disease. And this is really where the recommendation came from, to remove all MCNs. And I think in general, that is what's being challenged, because there may be some smaller low-risk MCNs, and also because people believe, and I believe this as well, that probably this number isn't real if you took all patients with MCNs. It's just that we don't perfectly identify MCNs, and many that we are following as side branch IPMNs may in fact be, I shouldn't say many, but some that we are following as presumed side branch IPMNs may in fact be MCNs. Okay, and just to review, IPMN, this is what really all the guidelines are centered around, and we'll talk about this for the rest of the talk today. Really, we'll only be talking about side branch IPMN by and large, but just to remind you, what we reviewed last week is that main duct IPMN is a kind of a different disease, and although there is a mixed type, you really can think about the treatment as being treatment of main duct or side branch disease. The main duct IPMN is obviously well illustrated in these two pictures, where the main duct is quite dilated. It's really easily recognizable. The diagnosis is not in question in patients who don't have chronic pancreatitis, and can easily be diagnosed at ERCP by seeing mucin extrude from the ampulla. The decision making is generally straightforward about if the patient needs an operation, and it's largely based on if the patient is physiologically fit for an operation. The question is really more what operation to do, and this is what we discussed last week in terms of deciding which part of the pancreas needs to be removed, and potentially if all of the pancreas should be removed in this setting. I think it's really important in that decision making to factor in if there is at least a very high likelihood that there's already an existing invasive component, and what location that might take. This is where pancreatoscopy and other imaging features can really help you. Okay, so side branch IPMN, this is our slide from last week, where really the pendulum in this disease is swinging most widely. The guidelines really all have to do with this back and forth. I think there's still, a lot of questions about how we should manage that, and that's why a lot of kind of institutional and international collaborations have tried to address this entity. Okay, so I just want to show you first the international consensus guidelines, the most recent variation, and when we get to reviewing the guidelines and comparing them, we'll talk about this in more detail. But basically, these guidelines start with imaging evidence of high-risk stigmata, then they go down to a term called worrisome features. This is, I think, it's a very confusing term for patients. Worrisome often sounds worse than high risk. I don't know, but these are the ones I would say that you would obviously do something about anyway, even if there were no guidelines, right? So the main duct greater than 1 centimeter, greater than or equal to 1 centimeter is patients with main duct IPMN. We would all agree based on the data accumulated to date that these patients should be operated on. Patients who have obstructive jaundice due to a cystic lesion, these patients are really very similar to pancreas adenocarcinoma patients and generally should get an operation. And then lastly, the patient has a mural nodule that has uptake and is bigger than 5 millimeters. This is essentially the equivalent of saying there's a solid mass in the pancreas. These patients are easy. We would operate on these patients really regardless, and I don't think there's much controversy here. So if none of those things arise, then we're in this bucket, which we nearly always are with patients with pancreatic cyst, and have to ask the questions of, did this cyst result in pancreatitis? Or the opposite question, which is really important, which is, did pancreatitis cause this cyst? And that can be difficult and really takes a little bit of digging in the patient's previous history and old films to sort out. And then on imaging, there are a variety of worrisome features, and we're going to go through and compare the types of worrisome features in different sets of guidelines in a bit, but I just want to kind of call these out here, as I think for the surgical residents, likely these are the ones that you'll hear cited most often by pancreas surgeons. So cysts greater than or equal to 3 centimeters. This has been demoted over time. It used to be kind of up in the category of needs to be resected, and now is one of the worrisome features. Enhancing mural nodules that are less than 5 millimeters. And the idea here is not that these are invasive cancers that are small that you can watch, but that the limit of our imaging resolution to adequately characterize an enhancing mural nodule that's 3 millimeters and be certain that it's in fact a solid component rather than mucin or some imaging related issue where, you know, something is caught at a in a plane that makes it appear to be nodular when it in fact is not, I think really is why this is put in the worrisome features category. I think as our imaging gets better, any enhancing mural nodules essentially will be high enough risk to be up here, but I think our resolution is still low enough that we're stuck kind of wondering about these patients. Then thickened or enhancing cyst walls. This is also a worrisome feature, kind of like nodularity. Main duct size that's enlarged but not at the threshold of 10 millimeters. An abrupt change in the caliber of the pancreatic duct with atrophy in the left pancreas. So this is always confusing, but basically there's a stricture in the let's say the body of the pancreas. There's a dilated duct with atrophy in the tail of the pancreas and the upstream pancreas. This is a concerning feature for in any case, regardless of if there's a cyst present or not. But if a cyst is resulting in this, we are concerned about the possibility that that cyst may have an invasive component. Lymphadenopathy, meaning peripancreatic lymphadenopathy, increased serum CA19-9, and cysts. These two are kind of recent additions to the worrisome features. And then the growth rate greater than 5 millimeters in 2 years, or 2.5 millimeters a year of growth, is outside of the expected range and thought to be a worrisome feature. So the bottom line is, if you have a worrisome feature, what's suggested by the ICG is that an endoscopic ultrasound is performed. Of course, usually an endoscopic ultrasound is performed up in the diagnostic phase as well. So generally this leaves you a little bit stuck, but the idea that is, if on endoscopic ultrasound a definite mural nodule is found that's greater than 5 millimeters, the main duct looks involved, or the cytology, of course, is suspicious or positive for malignancy, not for mucinous cells, then you go into this category and consider surgery if appropriate. we can talk about this later. That's essentially what we're going to these guidelines for, is to decide if the surgery is appropriate. But nevertheless, these patients should be considered for an operation. And I would say that I'm not sure this it really doesn't help you know which of these patients should be operated on. If there are none of these features, no worrisome features, then really the guidelines suggest that we base this on cyst size. Those cysts greater than, less than 1 centimeter, really what's suggested is some follow-up, but much more distant than those that are 1 to 2, 2 to 3, and greater than 3. This is an important thing to think about, which is that these cutoffs are very arbitrary. It's really unclear. There's a difference between a 1.8 and a 2.2 centimeter cyst. And similarly with greater than 3 centimeters, you can see that, that already puts you up here in a category where you perform endoscopic ultrasound. If you don't have any of these features and you're greater than 3 centimeters, I think the question is how closely and how to follow these patients. Currently, the ICG suggests close surveillance every 3 to 6 months with MRI and EUS. So invasive testing, perhaps as much as twice a year if you follow this strictly. And then an important point is that as you think about following this type of recommendation in a patient who's 30 or 40 years old, this could be many, many years of this. And the bigger question is, what should we do down here, which I'll talk about in a second. There's not much guidance as what to do over the period of surveillance. And so the ICG has added in this language over time that we should really consider resection or surgery in young patients who are fit, who have cysts that maybe have one worrisome feature, but none of these features on EUS. Okay, so I'll just pause for a minute and see if anybody has a question about just reviewing the ICG guidelines in general. And then I thought we'd go through the cases next. See if I can tell if anybody's. Or any comments from anyone, it would be great too. All right, I'm gonna go on then. Okay, so the bottom line on this, just to think about this, the ICG in 2 big categories. This is really only for IPMNs. For high-risk patients, you offer resection. For worrisome features, you essentially evaluate with EUS. Then once you get to EUS, you have these EUS high-risk features. If you have one of them, you offer resection, and if you don't, you offer surveillance. So in a sense, I mean, really most patients are starting early with an EUS, and you're just deciding at the beginning if the patient should go to resection based on the high-risk features or potentially surveillance, or if the worrisome feature is worrisome enough in that patient's clinical context that you would operate on them. I'm not going to review this again this week, but I just want to make sure you understand that I think this area is rapidly evolving. Right now, we're really stuck on clinical features and morphology, size of the cyst, nodularity, and some blood and fluid testing. Some cyst fluid genetics are being used, but I think we're really going to move towards an area of cyst fluid testing that's much more advanced, with panels of tests, kind of like liquid biopsies, and perhaps even use liquid serum biopsies eventually as well. And other features like glycemic control and germline testing and risk calculators that really incorporate the patient's overall medical condition, I think are evolving, as well as radiomic strategies to try to identify mucinous cysts by texture or other MR features, rather than simply relying on an invasive procedure like a cyst fluid aspirate to do that for us. So I think there's much to come in this field, and that's, for the trainees, actually, I think a really exciting place to be, because you can watch this disease evolve and the recommendations evolve over the course of your career. But it's important in this area, I think, to really keep up with the literature to date as well. Okay, so
I have a question. This is Ron, sorry. What if in the case where you have multiple IPMNs and you have a smaller one that's high risk, but a bigger one that doesn't have a lot of the high risk or worrisome features?
Yeah, so that's great, because a lot of these cysts are multifocal. So multifocality really complicates things for a lot of reasons. I will tell you, the one thing it does help you with is diagnosis. So if you have multiple cysts throughout the pancreas, you can pretty much, it's really not going to be an MCN or a serous cystadenoma, and generally not pseudocyst. So you can be pretty sure that that represents either mixed type or side branch IPMN. So then the question is, what do you do if one of the cysts is higher risk than the others? I think it kind of depends. Are those in the same part of the pancreas? Does the patient need an operation anyway? So for example, if the patient has a cyst in the head that's quite low risk and a cyst in the body or tail that's higher risk, but perhaps smaller, I think, is that what you said? A smaller cyst that has like a nodule or atrophy associated with the upstream obstruction? Arad, is that
yeah, that's what I was kind of getting at.
Yeah. Then, I mean, you should address the higher risk cyst in and of itself. Now, if you can, you're going to have to follow the patient regardless, in terms of, even if you take out a cyst that's high risk and there isn't other cystic disease in the pancreas, we still follow those patients to watch for the development of risk over time, of new cyst appearance over time and main pancreatic duct dilation. So you have to decide if it's worth changing your operation to resect the lower risk cysts. And I think the ones where it becomes a bigger problem are patients who just have a larger cyst somewhere else, and if it's in the head. So I think in general, you take each cyst by itself and then you kind of incorporate what the operation would be and what the impact of increasing the extent of the pancreatectomy for that particular patient would be. But it's one of the many problems with making a decision in patients with multiple pancreas cysts. Okay, good. So we did the case 1 last week, so I'm gonna just move on to case 2 just as an illustration of where some of these questions come up clinically. So this case is a 52-year-old woman who has mildly abnormal liver function tests. She got a CT scan that had a 2-centimeter cyst in her pancreatic tail. There was an MRCP. This did not show any evidence of ductal communication. She did not get an EUS because of the location of the cyst was I'll show you the picture in a second, but very far to the patient's left, where the window for aspiration and imaging is actually quite limited for the endoscopist. She had normal serum tumor markers and no family history suggestive of either familial adenocarcinoma syndrome or a neuroendocrine tumor syndrome. So here is this latest cyst way out here in the far left pancreas. You can see the pancreas parenchyma itself actually appears quite normal. And the cyst itself is nearly abutting the splenic capsule as well. You can also see her replaced right here coming off of her SMA. All right, so she has no symptoms, no comorbidities. The cyst is in the tail. It's at 2 centimeters. It's presumed to be mucinous. Now, it doesn't have typical features of serous cystic adenoma, and it's unclear whether this is an MCN or a side branch IPMN. It could be either, but given her age and its location, the idea that this is a mucinous cystic neoplasm is the, I think, presumptive clinical diagnosis, and hard to rule out the other options really any other way than resection in this patient. This could, I should also say, be an oligocystic serous cystadenoma as well. So the question is, yeah, how do we clinically distinguish between MCN and side branch IPMN? The classic teaching is, of course, that MCNs shouldn't have as high as cyst fluid amylase, but this isn't a black and white issue, and some people with MCNs amylase is higher than expected, and not all side branch IPMNs have an elevated amylase on the initial aspirates. So how should cystic lesions in the pancreatic tail in young women be evaluated? Do we assume that they're MCNs? Do we try to prove they're side branch IPMNs and follow them? And if they're young and we're going to be following them anyway, would it not be better to do essentially both a diagnostic and therapeutic operation? And how does the location in the tail change the threshold for resection? This patient ended up with a laparoscopic left pancreatectomy. It was, in fact, a side branch IPMN that measured 1.7 centimeters, had low-grade dysplasia, but there was also some low-grade dysplasia in the main pancreatic duct at the margin, suggesting that this is perhaps actually a mixed type disease and for something that the patient may end up having an issue in the future. So far, her follow-up was about 7 years. She developed a separate, nearly 1 centimeter cyst in the pancreas head that was being followed. So I think in this case, the question that really I bring this to your attention mostly to think about the concept of how to deal with cyst in the tail, how to deal with cyst that may be an MCN but could be something else, and really the limits of our testing ability. This could have been aspirated percutaneously, so I don't want to give you the idea that nothing could be done about this, and that sometimes an EUS can sample these lesions, but usually the splenic hilar vessels are precluding access to it, but certainly a transsplenic route could be undertaken. But when you put all this together and you ask yourself, what are you really going to do about this in the event the aspirate is non-mucinous, that's really where shared decision making with the patient comes into play, and you really have to talk over those options with them. So I will go on to case 3. This is kind of the opposite end of the spectrum. This is a 55-year-old man who has type 1 diabetes, complicated by both chronic renal insufficiency and coronary artery disease, whose functional status is limited by the effect of the diabetes on his retinas. And he has been undergoing an evaluation for kidney transplant, and as part of that, obtained an abdominal CT scan, which showed, unfortunately, a pancreatic head cyst. An MRCP was obtained, which showed some communication with the main pancreatic duct, and an EUS was performed, which showed this kind of multi-septated cystic mass without nodules or solid components. The cyst fluid CEA was 900, and the cytology was non-diagnostic. These are his images. These are non-contrast images given the renal dysfunction. And this is the cyst here and the medial aspect of the pancreatic head. This is the MRCP image of it. You can see the bile duct coming by. The main pancreatic duct is non-dilated. This is in the kind of most posterior aspect of the pancreatic head here. This is the EUS image. You can see it's got multiple different cystic components, and that conglomerate is measured here. So this is a man with no symptoms, but with significant comorbidities, no nodule, the lesions in the head. It's clearly mucinous, at least by serum by cyst fluid CEA, and it's presumed side branch IPMN. But the question, and this is one that's difficult to answer, is what do you do with a patient who you think is at somewhat higher risk of malignant degeneration of an already pre-malignant lesion, in the sense that he's going to be placed on immunosuppression post-kidney transplant, and if he in fact had a cancer, wouldn't be considered eligible for kidney transplant. So, you know, the effective immunosuppression is an open one. There are some data accumulating about this, but I think largely this is something that remains to be well worked out, and is not incorporated in any guidelines at present. You know, can the lesions be followed safely if we made the decisions not to resect? Meaning, how good is our surveillance for detecting pre-malignancy or invasive or in situ malignancy? And then, how should we factor in elevated perioperative risk? You know, this patient, I can't remember if he was just placed on dialysis or was trying to avoid it, but you know, it's a significant factor in thinking about his recovery. So after a lot of discussion amongst, this is at my previous institution, but a lot of discussion between the transplant team and the HPB team, decided to remove this lesion and underwent a Whipple procedure. His post-op course was not great, but not terrible. He had issues that were expected, and the pathology revealed a 2-centimeter side branch IPMN that did not have any evidence of high-grade dysplasia and had at most low-grade dysplasia. He recovered and was able to receive his kidney transplant about 1 year later. But, you know, all in all, the question is, if you knew this ahead of time, you could avoid this operation completely and potentially follow this patient, particularly if we had better data about the long-term impact of immunosuppression on pancreatic cystic disease. So this is not really to talk about the transplant issue so much, but just to show you that there are many clinical features that really are outside the guidelines altogether that you have to incorporate into the decision making. Okay, and so I think we have time. So I'll do the final case, and then we'll kind of back up and talk about more a bigger picture view of how we think about guidelines and what kind of recommendations we can make. Okay, so this is an 85-year-old man who had some left lower quadrant pain that was unrelated, went to the emergency room, got a CT scan. This is how many of the patients are showing up for evaluation, has a cyst in the pancreas head, but also has comorbidities of emphysema, atrial fibrillation, and coronary disease. He gets an EUS. This is over time he was evaluated. So the first EUS showed a 2.5 centimeter cyst with a mural nodule. The CEA in the cyst fluid was quite low, and the cytology showed mucinous cells, but no atypia. Later, he underwent a second endoscopic ultrasound. The cyst was now 4.5 centimeter. It had solid components. The cyst fluid CEA was elevated at this point in time. Probably, honestly, the same nature mucinous cyst is true between time point 1 and 2. It's just that the sampling and our ability to actually do this with consistency is not perfect. And the cytology again showed mucinous cells, just like the prior scan. His serum CA19-9 was measured at the time of the first EUS and was 300, which was elevated, but at the second time point had increased to 600. So here's his cystic lesion. His is in the pancreas head here. You can see it has septations within it. This is the axial image of it. So he has no symptoms. The symptoms of the pain went away and were thought to be early diverticulitis. He has significant comorbidity. It's a complex cyst that has nodules, though solid nodules. The lesion is in the head. His CEA is now elevated, and the question is, which do you believe? He had mucinous cells on each, so we really, I think, tend to ignore the CEA in this situation. There's definite growth over a year, more than was outlined in the worrisome features described earlier in the ICG criteria, and he has elevation in his serum CA19-9. So really, how much growth? This used to be an open question until it was added to the guidelines, but I'd say there's really not much data on which that number is based at this point. We have pretty limited natural history data. And so you have to really, I think carefully about that. How should we really think about the cytologic evidence of mucinous cells and without atypia? Does that make us feel any better or not? And then what about the serum CA19-9? The fact that it's going up or that it's just elevated as an absolute value is also really uncertain. So in this case, he got an operation, obviously to remove his pancreas head. He had some trouble after the operation that was fairly minor, but emphysema related. His hospital stay was a little bit prolonged. He had, on pathology, however, a 3 centimeter IPMN with low grade dysplasia and no evidence of things that we would have potentially suspected in the case of solid components. And his post-op CA19-9 never really came back down to normal. It just remained at 300. And his follow-up, I think, is around 4 to 5 years now. And so far, he's been fine and continues not to have significant trouble from his other comorbidities. But I would say, in retrospect, are you glad you took this out? I think it's really hard to know, and it really depends how much longer is the patient going to live, what else is going to threaten their life, and how. And in retrospect, he weathered it okay, but this could equally well have cost him his independence. This was a Wisconsin farmer who he was pretty sure he never wanted to live if he couldn't be independent on his own land. So, I think these are really challenging decisions, and honestly, we make the wrong decision. I think still in a fairly significant fraction of these patients, which we can only tell in retrospect. Okay, so I'm going to pause and see if there's any questions or comments about the cases, and then we're going to go on to kind of bigger picture stuff.
Hi, Emily. It's Ed McCarran.
Yeah, how are you?
Hey, good, thanks. Hey, so how much are the serum tumor markers a part of the workup of these cysts, and is that something we should order routinely, like the CA19-9, CEA, all that stuff?
Yeah, I mean, I think the ICG put that in for a good reason, and as did almost all the guidelines, that there is reasonable evidence that not necessarily the absolute value, but the trend is helpful. I think you have to explain to patients ahead of time, this is what the problem is, because many will have 60 or 80 or some number that isn't going to prompt you to operate, but often worries them. So I just think of it as a yearly part of the year. If patients are at diagnosis and then through surveillance as part of a yearly follow-up, one data point that you incorporate. So yeah, I do think that. I think, how much that one variable should impact us relative to others is really uncertain, but I think that's the standard of care probably at this point. Yeah. All right. All right. So I'm going to go on just to talk about kind of what we should do in general about these, and then I'll talk about the guidelines. So the easy rules are, and I think these are good resident kind of rules to just think about, is if something radiographically is a very typical microcystic serous cystadenoma, you really need to do nothing if asymptomatic. The one caveat is a lot of people will repeat an image at 6 or 12 months, just to have another data point to say, yes, this is not growing, this is a typical microserous cystadenoma. But I think it also wouldn't be wrong in the right clinical setting to say you need nothing further for patients with just typical microcystic serous cystadenoma by imaging alone, usually MR. Okay, so if it's a radiographically obvious IPMN of the main duct, the patient should get an operation if they're fit. To negative margins, meaning if you're going to not remove the whole pancreas, you should have no high-grade dysplasia at the margin. That's generally easy, although this question is obviously hard because many of these patients are elderly, and deciding if the patient's fit for a potential total pancreatectomy, which I think you have to consider in all cases, is not that easy, but at least this part is to know what we generally recommend. If the diagnosis is unclear, I think getting an EUS early in the triage phase with cyst fluid aspiration for CEA plus or minus cyst fluid genetics is actually really helpful for both making the diagnosis and for risk stratification. If something is likely to be a macrocystic serous cystadenoma based on clinical features and cyst fluid CEA, I think you should always do a follow-up study, because this is a difficult diagnosis to make and shouldn't be treated like the microcystic serous cystadenoma, and that these patients need some type of follow-up imaging over time to prove that you haven't in fact sent a patient with a side branch IPMN off without surveillance. If something is likely to be mucinous and less than 3 centimeters and was without concerning nodules or a dilated pancreatic duct, kind of weighing your options if the patient hasn't already had an EUS, but between watchful waiting and EUS, I think this is a difficult clinical dilemma, but you have to ask yourself, is there anything about the EUS other than a positive cytology, which is very rare, that will make me operate in this situation? And if there is, then of course the patient should get an EUS. And if there's not, I think putting the patient on a surveillance protocol is also acceptable. If something's likely to be mucinous and is greater than 3 centimeters or has nodules or other concerning features, if you're basically committed to resection already in this circumstance, which in many cases you should be based on the features of the cyst, then you really don't have to obtain an EUS, because it may be that the cyst fluid CEA is low, and then that likely isn't going to change your the testing properties are not specific enough to change your recommendation to leave in place a large cyst with neuronodularity or upstream pancreatic ductal obstruction or peripancreatic lymphadenopathy or high serum tumor markers. So you have to think about what the purpose of the EUS is if you're in fact recommending it. And then, follow up, we'll talk about this, but regular imaging and clinical evaluations and laboratory studies should be obtained. And I think this is where we probably have the most room for improvement in the current guidelines. And then really, you still have to tailor all decisions within these algorithms to the patient's preference, their physiologic age, and their health and overall history, meaning what has this cyst done over time. So that's what I think we'll talk about next. Okay, so I think the most practical suggestions are get old films, get old information. This can really help you understand the natural history of the patient's particular disease. You really need to take a careful family history, and I should say physical exam with this, to think about what is their risk for MEN, and if in fact this could be a cystic neuroendocrine tumor, or GI tumor risk, meaning if they have a strong family history of pancreas cancer or related cancers like colon, breast, endometrial, or melanoma, that you really should elevate your concern about those patients in pancreatic cysts more than you would in the absence of it. You have to really explain the knowns and the unknowns to the patient, and you have to really think about the purpose of surveillance and what you're going to do if the lesion does change over time before you embark on that pathway. I would say time is usually, or perhaps almost always, your friend if you use it that way in this disease, meaning putting a patient through a follow-up image at 3 to 6 months when you're thinking the patient should have an operation, in general, can be helpful both to the surgeon and to the patient in terms of thinking about proceeding with a major operative intervention, and is also fairly low risk in patients without the highest risk features. Okay, so we have a lot of things that we need to factor in, and I would say, you know, all of these things are relevant. What's the cost of surveillance? What's the benefit of learning the patient's natural history? What's the risk of comorbid disease? What's the perioperative and postoperative risk? What about patient and physician anxiety? I mean, for us, it's much harder to watch these, I think, because there is some uncertainty about if we're doing the right thing. There's the risk of resecting a benign tumor, the risk of not resecting a malignant tumor or one that will become that in the patient's lifetime, the risk of long-term follow-up testing. What's the downside of patients, for example, who can't get MRs and are getting a lot of CT scans? And what are the operative risk as well? So it's this is not really something that's easily put into an algorithm. And so I just want you to think about these discussions as some of the most fruitful if you're in a clinic seeing patients with pancreatic disease to listen in on, because they're probably some of the hardest decisions, at least that pancreas surgeons need to make. I thought I'd show you this. This was a message I got in my inbox from a patient who had a pancreatic cystic disease throughout. He had multifocal side branch IPMN with some main duct dilation. And he was 80-ish years old, young 80s, but very functional, and wanted some second opinions. And so he went around and got a series of second and third opinions and sent me this note when he was done saying that after my 2 recent visits to these other institutions for second opinions, 2 things strike me. This guy was a retired statistics professor from the UW. And he said, if there's truly such ambivalence about what would be best for me, surgery or observation, there must not be too big a difference between the 2. In that case, I'll choose the one that allows me to keep my pancreas and continue riding my bike with my grandson, and I'll just get my follow-up. This guy now is maybe about 10 years into this, and he's had some change and some cyst fluid aspirates that are concerning, but no malignancy, and actually continues to be pretty fit and active at, I think, now in his upper 80s. So anyway, this is a difficult decision, and I don't think this is necessarily the right one for most people, but I think this thinking is where we really need to improve. We really need to understand if there's a big difference between these 2 options, and in which specific cases in advance of making a decision for surgery or observation. Okay, so what I'm going to do now is pause and take questions, and I'm going to change over to the guideline focused talk. So go ahead if anybody has any questions. Now's a good time. Okay, I'm going to keep going then. Okay, so, you know, this question I think is one which everybody has, which like, which one of these guidelines do I follow? And I think the first one is like, okay, which guideline do I want to use, but should I follow it? Like, is this strictly something I should do? And is this a kind of a step-by-step guide, or how do I use it in the clinic? So I think you have to think very carefully about this part of it, which is what I want to emphasize in our last 15 minutes. Okay, so so here you can see a picture of a patient with multifocal side branch IPMN and a very normal pancreatic duct. This is, I think, an example of what Arad was asking about earlier. How do you deal with patients with multifocal disease, and what do you do with patients who have these cyst conglomerates and bigger cysts and more risky locations? So okay, so I thought I would just show you the timeline of guideline development. This isn't important that you understand all of these, but just so you'll hear this. This really began with the ASGE, the Gastroenterology group, in 2005. And then the first international consensus guideline, really known as the Sendai guidelines, was published in 2006, the following year. Then the another GI group, the ACG, put something out in 2007. And then the radiology group, the ACR, in 2010. And then 6 years after the Sendai guidelines, the revised international consensus guidelines were published, known as the Fukuoka guidelines, or some people called this the Sendai 2 guidelines. And that was 2012. 2013, there was a European consensus guideline. And I should say that the international consensus guidelines, this group did include many of these same authors. Then there was an Italian consensus statement, also some overlap between the, at least the institutions in these two cases. Then the AGA, so this is a third GI group. There's the ASGE, the ACG, and the AGA, each had their own set of guidelines. Then the ASGE or revision, so about 10 years between these two sets of guidelines. The revised ICG, which now is the third rendition, was held back in Sendai. It's a little confusing. These are often called the modified Fukuoka or the Sendai guidelines. I think calling them just the 2017 ICG guidelines is perhaps the most useful. The 2017 ACR revision, this was a white paper revision, occurred in 2017. 2018, there was a revision of the ACG guideline, European revision after a period of about 5 years, and then the World GI Organization in 2019. So this is, when people say, oh, the guidelines told me to do it, the question is always, well, what guideline and how did you pick it and how do you think about this? So, right now I would say in many organizations, we sit somewhere like this where the surgeons are talking about these guidelines, modified, Fukuoka, Sendai, et cetera, really using ICG language. The radiologists are frequently still citing the white paper, incidentalloma papers that they published most recently. And I think that's often what you see in reports. And then the GI groups are talking about one of these, ASGE, ACG, AGA, or the WGO. And so this can put us all on a little bit different page, and it's pretty confusing to patients and I think also to trainees. So I just want to introduce this concept now before I move on, because I'm not really going to talk about this, but there are some non-guidelines that are out there that are in use. And I think the Verona concept is something that really is very useful because it talks about two separate phases and the rest of the guidelines really don't do this. They act like it's like a one-step process followed by surveillance. Whereas the Verona group, and I really think rightly so, has emphasized that there's a picture phase and a movie phase. Here's the initial phase, and many of these criteria are just what we've discussed above. You make an initial decision about surgery, absolute indication, relative indications, and EUS can help you here. But then most of the patients are going to be somewhere in here, and really there is this phase of watching what unfolds and trying to figure out how this can help you make the decision about what to do, and that you need to incorporate the patient's fitness, the patient's preferences, what you think the diagnosis is, and then make sure you've evaluated the clinical features. Well, they talk about this a lot, which I think is an interesting imaging concept, which is really we're imaging the shape of water. We're not imaging a mass in this case. And so that there are limitations to that. So I put this up only to show you that I don't think everything needs to come from the guidelines. And I think there are some really useful concepts by groups that are really experienced. This is Claudio Bossi's group. And I think I tend to lean towards this type of approach in general, that it's not as easy as a simple algorithm. Okay, so what about comparing guidelines? I thought, that it'd be useful to just make two distinctions, that we could compare guidelines between the same guideline. I made the colors the same so you could see, but the ACR one to another, the European consensus one to another, that's really not that useful, except to understand how groups have changed their thinking over time. But really to compare different groups to one another is really the purpose of what I wanted to do today. So this is, these are the Sendai, Fukuoka, and ICG papers, and you can see the same, in case you felt bad enough about your own academic productivity here, you can see the same author, all three papers over this long period of time, has put out these three things. And I would say it's really important to think about here that the core of what your, that the core of a guideline will often persist, but things over time start to look and sound somewhat different within a given group. So this is the way I think about it. There's growth, the development, things are a lot messier with time as the guidelines go on, things are less clear in some areas, and that it becomes more complicated. So today I just want to talk about the AGA guideline, the revised ICG, which we've already reviewed somewhat, and the ACR and European revisions. And I'll try to just compare and contrast some of the high level features of these. Sorry, let me just, I gotta send our fellow a quick text. Okay, so this is the ICG. Sorry, it's a little problem. Okay, the ICG ones that we just talked about, so I'm not going to review those again. This is the European guidelines, and you can see they start in a really different place. They start with, is this a radiographically suspected IPMN? And then importantly, how is the patient unfit for surgery? That's very, I think, practical solution. If the patient isn't fit for surgery, honestly, why are we doing additional tests? If it's an invasive cancer, it makes sense because there are other treatment options. But if it's a cyst without solid components that isn't likely to have an invasive cancer at the time of diagnosis, really, these patients, they say no further follow-up. But I think this stratification about the patient's ability to undergo surgery up front is really important. And then, this is their period of follow-up. I'm going to compare and contrast these in a second. But for the residents, if you're looking for another app for your phone, these are the European guidelines put into app form called Pancreas Guidelines. They're free. You can just go and install them. And you can see basically how they recommend. And they're similar enough that I actually think this is useful to use, or at least to reference for those of you who are still learning about this. And then this is the radiology group, the incidental pancreas cyst white paper. And their approach is complicated, which is why I just wanted to summarize it for you here. They have 5 separate algorithms. They take any incidental cyst in patients greater than 80 and make that one category. They have any incidental cyst in patients less than 80, that is more than 2.5 centimeters. Then they take cysts that are less than a centimeter for patients in these 2 groups, less than 80, and then incidental cysts between 1.5 and 2.5, and then with and without main duct communication algorithm. So this is fairly complicated, and I'll say that this grouping and these cutoffs, really none of this is particularly data driven in any of the guidelines. So, but it's in some sense the bias of the non-clinician. I think looking at patient ages as a dichotomous variable, and kind of physiologic age is harder to incorporate in algorithms. But so this is an example of what it looks like where the patient has a greater than 2.5 centimeter incidental pancreas cyst, and this is in patients less than 80. And they basically use low risk. So they basically say the diagnosis of serous adenoma should be made by imaging if it's a serous adenoma, or if it's low or high risk by imaging, and basically suggest many of the same strategies. But you can see that they incorporate EUS, but this decision making about how to proceed here is not very well outlined by the white paper. Okay, then there's the AGA. I thought I'd just show you how they do it. They basically just have summary of the evidence, and then they make isolated recommendations that look like this. So let me just compare the patient populations for you. Let me just make sure this patient's okay. So the AGA starts with asymptomatic neoplastic pancreas cyst and excludes any of these others. The ICG has now narrowed down to only suspected branch duct IPMN and said MCNs are no longer included in the algorithm because these should all be resected. The main duct IPMN is sort of included because they talk about the size of the main duct, but and then they include both symptomatic and asymptomatic patients. The ACR is really only incidental cyst, and the European takes all pancreatic cystic neoplasms. So, and really the high-risk stigmata in many, but not all of the guidelines are the ones we've already discussed. And I would just say that this is obvious. This isn't something you need to think that carefully about because these are patients you would all make the same decisions on regardless of the cystic components. This is where it's different, is where people take the individual worrisome features, and they're called out in some guidelines, but not others. So, the neural nodule, it's some guidelines it's dichotomous, yes or no, whereas in others it depends if it's enhancing. Main duct dilation size varies over different guidelines. Only the ICG incorporates the change in the pancreatic duct caliber, lymphadenopathy, or the elevated CA19-9 at this point in time. Cyst growth is in different guidelines counted differently. It's more than 5 millimeters a year in the European guidelines, but over 2 years in the ICG, and then greater than 20% increase in the mean axial diameter in the ACR. And then the European guidelines incorporate currently the new onset diabetes, which I think actually will probably filter over to the ICG fairly soon in the next iteration. So this is, you can see there's not universal agreement, and when somebody is worried about a certain clinical feature, it's it really depends what guideline you're using, what you call it, but I think everything on this list is at some level of concern and should be treated as part of the clinical algorithm. In terms of how to talk about surgery, you know, there's a lot of offer surgery, consider surgery if it's appropriate. The ACR just says you should get a surgery consultation, which honestly, that doesn't help us at all. Like, we really are trying to decide if the patient should have an operation or not. And then, you know, the European guidelines have an interesting assessment, which is if they have a feature and no significant comorbidity, or 2 features and significant comorbidity. So they are trying to incorporate kind of how we are making a decision about the risk of surgery compared to the risk of the cyst. The duration of follow-up, you know, is variable, and I think this is going to change based on some recent data about post 5-year surveillance and the risk of cancer in that time period. But right now, the AGA says you stop follow-up at 5 years. This was extremely controversial, and I don't think is really something that they're likely to stand behind for very long. The ICG has indefinite follow-up, but of course, comprehensive clinical judgment if the patient becomes no longer fit for surgery or the cyst appears to be lower risk over time. The ACR says you either stop at 9 or 10 years, depending on cyst size and the stability, or 5 years if the patient's more than 80, and the European guidelines have indefinite follow-up. So the flavor of each of these guidelines is different. I mean, the AGA basically says there's no evidence. That means we should have no action, right? So they're very nihilistic about operating on patients, I think, overall with high-risk stigmata, and they're very conservative with the US, whereas the ICG is really focused on EUS as essential to decision-making, and it's more liberal with surgical interventions overall. The ACR is really using patient age as a really essential variable. They're very conservative about the use of EUS. They assume that imaging can tell you if the lesion is mucinous. They have a heavy reliance on imaging features and stability over time to predict biology, which is not yet really data-driven at this point. And the European guidelines consider fitness for surgery paramount to the workup and incorporate comorbidity, reliance on clinical factors, and special circumstances. So I know we don't have much time left, so I think what I'll do is just skip to this point, which is really to show you that when we're making decisions about this, I think, you know, this is what the first phase is. This is detected, and we're trying to say the number one task is diagnosis. Does this fall in the group of benign, pre-malignant, or malignant? Then we're really, for the pre-malignant group, trying to do risk stratification between low risk and high risk. These are easy. If it's malignant, we're going to take it out. If it's benign, we're going to do nothing. The problem is in between the low and high risk patients with pre-malignant disease. If it's high risk, we're probably going to remove and then watch the patient. So we have a surveillance part. The guidelines help us some with this, but they do very little on either end of this. And this is where I think it's really important to think about. So the majority of the difficult decision making is way down here, and the guidance from any guideline in this situation is quite limited, other than the one number about growth.